going to do a basic gastrointestinal examination today. This will be in 3 parts. The first will be a general examination of the abdomen. The second part will be a specific examination for an enlarged spleen. And the third part will be a specific examination for liver disease. Once again, Todd has agreed to be our subject for this. Thank you, Todd. You'll notice that I have Todd lying perfectly flat. This is a little uncomfortable for most patients, but does allow the best examination of the abdomen by relaxing the abdominal muscles. If patients are really uncomfortable, it's possible to use a folded sheet or a thin pillow under their head. I'm going to start by looking general inspection. I'm looking to see if Todd has any evidence of overall pallor, if he looks uncomfortable or sweaty, if he looks yellow or jaundiced, and if there are any scars in the abdomen. I just have to lower this very slightly to ensure that I can see the lower part of the abdomen for scars. The order of the abdominal examination is a little different from the usual inspection, palpation, percussion, and auscultation. The reason for that is that palpation of the abdomen can change the quality and intensity of bowel sounds. So I'm going to perform auscultation next. And I've listened in all 4 quadrants and I can hear bowel sounds. You don't have to be able to hear bowel sounds in all 4 quadrants. It's reasonable to be able to hear bowel sounds in only one area. The intensity of bowel sounds can vary from very quiet or absent to loud and very rushed. And you'll learn in your lectures the difference in quality of bowel sounds. I'm going to perform percussion, bearing in mind that there are organs that can be enlarged in the abdomen, including the liver, the spleen, the bladder. In women, the uterus and ovaries can also be enlarged, so my percussion will have that in mind. I'm going to start in an area which I normally expect to be resonant, and that is over the stomach, which is full of gas, and then compare that in all 4 quadrants. And I'm looking at Todd's face to see if there's any evidence of tenderness while I'm percussing, and I don't see any of that. I'm going to perform light palpation, and it's important to ask the patient if there's any part of their abdomen that hurts if I press on.
All good.
Oh, good, thank you. Again, I'm going to perform this using a quadrant approach. This is very superficial. And again, I'm concentrating to see if there's any evidence of tenderness. I'm going to press a little deeper, again looking for evidence of tenderness, but also feeling for a tensing of the muscles, so-called guarding. Guarding can be voluntary. People can tense the muscles just in response to the pressure, or involuntary if there's peritonitis, in which case the muscles will be tense to protect the abdominal structures. If someone has guarding, it's important to look for rebound tenderness. Rebound tenderness occurs in patients who have peritonitis. It's elicited by pressing down, watching the patient's face, and then suddenly releasing the pressure. In patients with rebound tenderness, the sudden release of pressure causes movement of the peritoneum and increases the pain. So I have found no abnormalities on the general examination of the abdomen. I could find normal bowel sounds. I felt no masses on superficial palpation, no masses on deep palpation. There was no evidence of guarding or tenderness. So the general part of the examination of the abdomen is normal.